This is Willie Kemp. This is Conditions Causing Decreased Production, Part 2. This is the 7th of the 7 lectures I'm going to do on anemia. There are my websites I do with Dr. Hughes. There are questions available there. Also, there are my Twitter sites, which I haven't used both those for a while, or the USMLE questions, but I'm going to start doing that more regularly. And as I said, I'm a forensic pathologist, not a hematopathologist, but I have a very strong interest in just general pathology, general organ pathology, i.e. not traumatic pathology necessarily, and I have a strong interest in teaching medical students. Here are my disclaimers. Please read these. Make sure you agree with them before you go on with the lecture. If you don't agree, stop. One more disclaimer. Once again, if you don't agree with it, just don't continue. And then the last one is, just in case you want to understand my teaching style or whatever, there's a lecture I made that kind of explains it, if you would like. Here are my references. This will be specific conditions leading to decreased production of red blood cells. So at the beginning of this, as I say, I always have a question. The idea is stop, look at the question, see if you can answer it. The idea is you don't have the information yet, and so you can't answer it, but it'll guide you as you go through the lecture trying to find the answer, and it helps with retention. And I actually have 2 questions this time. Here's the first one. Here's the second one. So we're going to talk about folate and B12 deficiency. So we'll talk a little bit about their general importance. So dietary B12 is bound to haptocorin, hopefully I pronounced these correctly, in the saliva, and then that complex comes in, a pancreatic protease cleaves it, releases the B12, and that binds to intrinsic factor, which comes from the parietal cells in the gastric mucosa. And this is very important because one reason for B12 deficiency is things like pernicious anemia, damage to the stomach, and then you don't make the intrinsic factor. So if you can't bind the B12, it can't be absorbed. That intrinsic factor in B12 complex binds to cubolin, which is in the distal ileum, enters into the enterocyte, and then it's transported through the blood bound to transcobalamin. The functions of B12, it has a relatively few number of functions. It converts homocysteine to methionine using methionine synthase, and B12 is the cofactor. And it also converts methylmalonyl-CoA to succinyl-CoA using the enzyme L-methylmalonyl-CoA mutase. And the thing about this is I put these on here because I know as biochemistry people don't including myself, don't necessarily want to relearn all of that. But I think when it applies to what you do clinically, it's very important. So the thing about it is that these are actually laboratory tests. So one way to look for, because with both B12 and folate deficiency, you'll get an elevated level of homocysteine, but only with B12 will you get an elevated level of methylmalonic acid. So it's biochemistry based upon the vitamin deficiency that applies to the laboratory testing. And I think those are very useful to learn because it's always nice to know when you order something or give something to a patient or things like that, why? What am I doing? How is this helping? What's the underlying reason for that? And I think it gives you more appreciation for what you're doing, and you can understand it better than just memorizing it. So folate functions, it says folate actually does a lot of 1-carbon transfers, transfers methyl and formyl groups. So it's very important in the formation of, through thymidylate synthase of DTMP. And also, as I just said, it helps convert homocysteine to methionine. And so both B12 or folate deficiency, either of them, can lead to an elevated level of homocysteine, but only B12 will lead to the methylmalonic acid. So megaloblastic anemia is what you can see with folate and B12 deficiency. You can also see just more of a macrocytic. I think to get megaloblastic, it's like a MCV of 125 or greater, somewhere around there, whereas just greater than 100 is macrocytic. But obviously, remember, a lot of these, like for example, iron deficiency isn't automatically low MCV at first. You can have a normal MCV. So same thing here. You could have a less than megaloblastic level of anemia, like an MCV like maybe 105, it could still potentially be B12 or folate deficiency just early on. So they're both decreased red blood cell production. Megaloblastic anemia is usually due to a deficiency of folate or B12. The mechanism is that impaired synthesis of thymidylate, and that's needed for DNA replication, but not RNA replication. And what this leads to is nuclear cytoplasmic asynchrony. So for the longest time, I didn't understand this concept, but actually I do now after I've gone through it a couple times. So what happens is, because you can't make DNA, the DNA production, maturation, that is slower, but it's behind RNA, which goes with most of the rest of the cell. So you'll get this nuclear cytoplasmic asynchrony because of that, because the DNA production can't go at the same rate it's supposed to, but the RNA can. They are asynchronous. So I think it's just kind of neat to understand that. So the clinical features, you can see anemia, but also thrombocytopenia and granulocytopenia. So I think usually when people think of megaloblastic anemia, they only think of the red blood cell component, but it plays a role in the other ones. They're just not affected quite as much. So the pathology is very classic. In the blood, you see hypersegmented neutrophils. They will have 5 or more lobes, or 5 plus lobes. You can see oval macrocytes, the increased size. And then in the bone marrow, obviously, you can see megaloblasts, so enlarged red blood cell precursors. You can see giant metamyelocytes and large megakaryocytes, which goes along with the fact that you can have not only anemia, but also a thrombocytopenia and a granulocytopenia. So the hypersegmented neutrophil, here's an example of it. You have 5 plus lobes. This one has 1, 2, 3, 4, 5. Seems like I can count 7 there. You may count less or more. But it's definitely hypersegmented. So this would go along with a B12 or folate. And I always tell students there's about like 100 pictures that I could choose that are like classic pathology. This would be my top 100. So this is just comparing the B12 deficiency and the folate deficiency. B12 deficiency etiology is oftentimes a diet, but it can occur in vegetarians who don't eat eggs or milk. And then it says also, and then abnormalities of B12 absorption. It says B12 deficiency due to diet is relatively rare because we have pretty good stores of it. But understanding how B12 is absorbed, especially the intrinsic factor binding to the B12 and the necessity of that, can help you understand how certain disease would give you that deficiency. Folate deficiency, it says, is much easier because in the diet it's lost with cooking, and so a lot of people aren't getting as much folate as they need. And then it says anybody with increased metabolic requirements. So same thing with iron. Pregnancy has increased metabolic requirements. And I think a lot of people know the complications of folate deficiency in women. You can also potentially have malabsorption. So B12 deficiency, remember, has neurological clinical features and non-neurologic, whereas folate only has the non-neurologic that would go along with the anemia. So weakness, fatigue. It says you can also have GI tract symptoms. It's probably related to the fact that the cells they turn over quite frequently, and they don't have that ability to produce the DNA as correctly, and so therefore don't develop normally. But B12 deficiency also has neurological clinical features. It says it causes demyelination of the posterior and lateral columns of the spinal cord. Patients will have numbness, burning, tingling, unsteady gait, and loss of position sense. And it also says that they're tied together too. So the problem is if you diagnose a folate deficiency, there's a chance there actually might be a B12 deficiency, and the person could develop those neurological symptoms. So from what I was reading, it sounds like it's good to supplement both to make sure. So this is what I talk about with the biochemistry, the methylmalonic acid and the homocysteine. So with folate deficiency or B12 deficiency, since they're both needed to convert homocysteine to methionine, they'll have an increased level of that in both of them. However, the folate does not play a role in the conversion of methylmalonic acid, the methylmalonic-CoA to succinyl-CoA like B12 does. So with a B12 deficiency, you'll have an elevated level of methylmalonic acid, but you won't have that in folate. So it's a good laboratory test to know if you need to separate out the two. So like I said, once again, knowing the biochemistry helps you understand the lab testing, and then you're not just memorizing, you're understanding it. So the specific mechanisms of B12 deficiency, pernicious anemia, as I mentioned before. If you have injury to the parietal cells, which produce the intrinsic factor, it can't bind the B12, you can't absorb it. It says they also can have, usually they have antibodies directly against the parietal cells, but they can also have it against the, that combine the B12, combined to the B12 intrinsic factor complex, but it says these are not usually the primary cause of the disease. Gastrectomy, you lose the parietal cells that way. Ileal resection, since the B12 intrinsic factor complex is absorbed in the ileum. And then any diseases of the distal ileum, Crohn's disease, Whipple's disease, that could also cause B12 deficiency. And I think these are good test questions, that kind of complexity of the whole process and the different places it's absorbed, what's required to absorb it, the symptoms they could have in that. Okay, so here's my picture for halfway through. This was a coyote. I believe this was in the Billings Zoo. Just kind of cute little guy there. So, okay, aplastic anemia. This is due to a multipotent myeloid stem cells that do not produce mature red blood cells. White blood cells are platelets. So aplastic, no cells basically. And so anemia is kind of a little bit of a misnomer because it affects a lot more than just the red blood cells. But it says it can be due to an intrinsic defect in stem cells, or it can be immune mediated. Causes of it, EBV is one, which I think on a test, if there's ever a possibility of listing an EBV for a tumor or something like that, I'd put it. Medications can do it. Here are some: anticonvulsants, chloramphenicol. You can see in pregnancy, radiation, certain forms of toxins, benzene was one, and malignancy. So there are a wide range of stuff where it kind of just wipes out the bone marrow. Both sexes, all ages, because you can probably tell that from there's just so many different underlying causes of it. So what you can see is, remember, one thing I think that's really neat about when disease affects the bone marrow, so whether it's aplastic anemia, whether it's an infiltrative disease that's wiping out the bone marrow, you can always figure out the way to present by just thinking of what's there. So you have red blood cells are there, so if you're not producing those, you become anemic, which could be the weakness, the fatigue, the pallor. You're not producing platelets, so they'll have bleeding issues, and you're not producing white blood cells, so they can get infections. And so it kind of, if you just think about what's going on in the bone marrow, destroying what normally should be there and what you lose because of it helps you think through the symptoms. And one important point said in Robbins is there's no splenomegaly with this. So pure red cell aplasia is just where you have a lack of formation of red blood cells, but actually granulocytes and platelets are made just fine. Just affects the red blood cells. Underlying causes can include a thymoma, so that's also associated with myasthenia gravis. Different types of viral infection can do it. Parvovirus, B19, always remember, affects the early erythroid precursors. Neoplasia can do it. Connective tissue disease, different medications, pregnancy, and then this one requires a bone marrow biopsy for diagnosis. And finally, for decreased production, myelocystic anemia. This is where you have infiltration of the bone marrow by a neoplasm or other process, so granulomas and sarcoidosis or that. Here are some of the common neoplasms that can do it. Prostate, goes to the bone, lung, breast. Others, tuberculosis, granuloma disease, as I said. And then what you have is basically a wipe out of the bone marrow, so you would have features associated with the loss of red blood cell production as well as white blood cell production and platelet production. And then remember, in the first section we talked about, these have the classic teardrop cell. It's like a little red blood cell just pulling its way out of the fibrosis, so it stretches itself out and looks like a teardrop. And then you can see immature granulocytes and erythrocytes. So anytime you kind of are producing stuff and have to get out quicker, there's a chance you might see more immature cells. Okay, so here's just an example of a myelocystic process. This is just fibrosis, which you can see the bone in there, and then you can see there's no bone marrow. Everything's been wiped out. Okay, so the first of two questions, like I said, once again, pause, look at it, answer it, and then we'll discuss it. So a 42-year-old female is brought to her family physician by her husband. She has, over the course of a few months, had pain in her legs. She describes as pins and needles, so neurological changes, but did not want to seek care. However, recently she has been stumbling, sometimes falling, and he's concerned for her. She doesn't smoke or drink and follows a typical diet, including vegetables and meat, mostly chicken. Laboratory testing reveals elevated MCV, of the following was the most likely mechanism for her disease process, and of those, the likely thing would be anti-parietal cell antibodies. So if she has some type of pernicious anemia that's developing into a B12 deficiency because of the inability to produce intrinsic factor, that would explain the neurologic symptoms, and then it would explain a macrocytic megaloblastic anemia. Okay, and then there's the answer and the description I wrote. Second question. Okay, a 67-year-old male presents to his primary care physician with complaints of fatigue and shortness of breath. These symptoms started about 3 months ago and have been progressing. A white blood cell count reveals anemia, thrombocytopenia, and leukopenia. Of the following was most likely diagnosis. So it's myelofibrosis. So anemia of chronic disease would produce anemia, but not the low platelets, low white cells. Iron deficiency would produce anemia, but not the low platelets and white blood cells. Thrombotic thrombocytopenia purpura will produce anemia and thrombocytopenia, but not the leukopenia. And thalassemia will produce the low red blood cells, but not the low platelets and low granulocytes. And then here's the explanation. And then once again, I just recommend using reflection, pause the recording, think back, and go, okay, what are 5 important points that he made? And this is a really good way to cement the material in. And like I said, once again, I hope I made 5 important points. And just it's really a really excellent tool, and I use this quite frequently myself. I used to do it a lot of time in college and never even realized what I was doing, but it works really well. And so here are 2 mountain lions at the Billings Zoo. I hope this lecture has helped you understand anemia. I hope all 7 lectures have helped you understand anemia. If you have any comments for me, please feel free to leave them on my YouTube site. I'm going to try and be a lot more active and put out a lot more of these lectures more rapidly, and try and produce a whole group that would be useful for you all to study and everything like that. But I'm open to comments or any suggestions or anything like that. Otherwise, thank you.